Hello and welcome. My name is Dr. Ernesto Lee, and I'm the director of the Periodontal Prosthesis Program at the University of Pennsylvania in Philadelphia. Many of you are aware of the fact that this is a program with a long-standing tradition of excellence in interdisciplinary therapy, having been founded approximately 60 years ago by Dr. Morton Amsterdam. We unfortunately lost Dr. Amsterdam last year, and I want to take this opportunity to dedicate this presentation in his memory. Today we're going to speak about aesthetics and implant therapy, specifically about immediate implant placement and provisionalization, describing the protocol we have been using in our program since 2007 with predictable and successful aesthetic outcomes. One of the difficulties in discussing aesthetics and implant therapy is the fact that the literature has traditionally focused on implant success and survival rates, and that the aesthetic parameters have been underexposed in most clinical trials. Adding to this, we have a lack of objective or uniform criteria for implant aesthetics. This improved with the introduction of the Pink Aesthetic Score by Forhauser and co-workers in 2005. And if you take a look at all the parameters included, they're all soft tissue related. And this is so because when it comes to aesthetics around implants, the nature of the peri-implant soft tissues is much more essential and much more difficult to achieve as well than the white tissue or ceramic type of aesthetics. So the first question that we're going to ask ourselves is whether or not there are certain types of cases or implant scenarios that are more conducive to predictable aesthetics. And Belzer answered this question in 2004 during a review of the literature where he was able to identify 4 different types of cases that were reported with respect to aesthetic outcomes. Of these 4 different scenarios, the only one that was predictably reported to result in aesthetic outcomes was a single tooth implant. And I believe that most of us will agree with this outcome. Particularly in size without tissue deficiencies, we can get good results because of the fact that the tissue support is provided by the adjacent teeth. In situations where we have defects like the ones you see in the screen, it is going to be very challenging to get a good results with implant therapy. It's going to require a number of procedures, and the outcome of these procedures may be questionable many times. So there are a couple possibilities when it comes to single implant therapy in the aesthetic zone. One is that the patient may show up in your office with the tooth already missing, and in this case, we have no choice but to offer a traditional or delayed approach. The other possibility is that the patient presents with a tooth that needs to be extracted but is still present, and in that case, there's an opportunity to utilize an immediate implant placement and provisionalization type of protocol. So let's take a look first at the edentulous type of situation where the patient presents with a tooth that's already missing. This is a scenario where we may need to consider both hard and soft tissue grafting, and this may involve multiple procedures, following which there's going to be a process of prosthetic tissue modeling involved as well. As an example, let me show you this case. I was referred to our office by a general dentist, and in this situation, this patient had an implant that had failed previously, placed by a colleague oral surgeon of ours, and you can see that there's also an abundance of keratinized tissue, which is a result of multiple soft tissue grafting procedures that were performed during the time or around the placement of the initial implant, which had subsequently failed. Once the flap is reflected, we can now appreciate the architecture and morphology of the defect, which is subsequently grafted, and in this case we utilize a non-resorbable membrane. And following a period of several months for graft consolidation, we can appreciate the amount of regeneration which allows us to place the implant as well. The implant integrates, it is exposed, and then we're going to start a process of prosthetic tissue development. And this tissue modeling will involve having to modify either by addition or subtraction of a composite around a temporary cylinder, and also modifications in the contour of a temporary restoration. The purpose is to gradually develop a peri-implant soft tissue contour that's ideal and will lead to the appearance of a final restoration that appears to be emerging from the soft tissue as a natural tooth does. This could be a cumbersome type of process which may require several appointments. Once the ideal peri-implant soft tissue contours are developed, then they have to be transferred to the laboratory environment. For these purposes, I usually prefer in these situations to use a customized impression coping. However, here we have a couple interesting situations. One is the fact that there's a fair amount of keratinized gingiva which is preventing soft tissue collapse. The other factor to consider is the fact that given the shape of the peri-implant soft tissues, there is no impingement caused by the stock impression coping. So therefore, we can actually, this is a case where one of those exceptions where we can actually use a stock impression coping. The laboratory eventually returns to us a custom milled zirconia abutment and an associated restoration which we place definitively. As you can see the appearance here, and just to make clear that a decision had been made early on to make this restoration conform to the adjacent dentistry, which was, if not outstandingly aesthetic, it was certainly very adequate and acceptable to the patient and all parties involved. So the next consideration has to do with a situation where the patient presents with the tooth still in place. And this is a situation where we may consider immediate implant placement and provisionalization. This technique has become very popular recently because it is conservative and efficient, many times resulting in decreased treatment duration with less expense and morbidity to the patient while providing predictable aesthetic results and similar survival rates as a traditional technique. For us, the first case in which we contemplated the use of this immediate implant placement and provisionalization technique was in 2004, and this is a case that was referred to by the orthodontist following completion of therapy, and you can see it's a very thin biotype type of case. The maxillary right central incisor was ankylosed and in for occlusion, and you can appreciate the fact that there is a fair amount of tissue inflammation present, particularly going into the papilla. And if you were to basically use an explorer, you could trace a soft tissue going into a resorption type of cavity. The white material you see on the base of the papilla is actually tooth structure that has been, it's a fragment of tooth structure that's being exfoliated. So in this case, we consider this a very high risk type of potential, and we were considering then the possibility of utilizing an immediate implant placement type of protocol. Back in these days, there are only a couple publications, and there are two case series by Peter Worley and Joel Kahn, both reporting favorable results. If we further take a look at the radiographic appearance, you see that there's a substantial cavity that is secondary to the resorption, and at the same time, there's the long axis of the teeth have a fan-shaped appearance where they converge towards the apex. This is so because this patient presented initially with an edge-to-edge type of skeletal tendency, which is compensated for orthodontically by proclining the maxillary anterior teeth, and in so doing, decreasing the width of the buccal plate and increasing the risk level of this type of patient. So the question then became one of whether we're going to utilize an immediate approach or a delayed approach. And if we take a look once again at the clinical signs, here we have a tooth that's present with an intact socket in an acceptable position. So we're calling this acceptable because the patient stated that he would agree to have an implant placed and subsequently restored as long as the gingival margin remained at this position and not higher. It is a thin biotype, which basically means that we have an increased risk profile. So the rationale for treatment in this case was that we were going to attempt an extraction of this tooth and to preserve the buccal plate intact. If we were able to achieve that, then we'll attempt the placement of an immediate implant followed by an immediate provisional restoration as well. If the buccal plate was injured during the process or lost during the process, then we'll default to a traditional or delayed approach. So as it happens in many instances in cases like this, the tooth fracture due to the tremendous amount of missing tooth structure, we then carefully had to elevate the residual root and then meticulously inspect the buccal plate. And once we found that it was intact with no damage, we proceeded with the flapless approach, initiating an osteotomy that was substantially biased towards the lingual. Why towards the lingual? Well, for the simple reason back in those days that we had struggled to keep the buccal plate, and it made no sense to us, and now we're going to lose it secondary as a result of the drilling of the osteotomy or even the impingement from the implant placement. So at the time, it was a very simplistic reason to keep the implant away from the buccal plate because we wanted to avert any potential damage. So if the implant is now placed towards the lingual, this results in a gap or a space between the implant surface and the buccal plate. That gap was grafted with a xenograft, and the implant was actually placed with an insertion torque of 45 centimeter minimum. This was so following the guidelines published by both of the case series that I previously mentioned by Peter Worley and Joel Kahn. You can see now how the case was provisionalized and for occlusion, again, to avoid any type of occlusal loading issues. And then you see the appearance at 2-week post-op and then 1 year follow-up following completion of the case, including the final restoration. So this patient went to college, came back the following summer, and we're able to see him now for a follow-up. Oral hygiene is not great, and what do you expect? He's a college freshman. So then the next assessment is whether or not this is an adequate result. Well, from the perspective of having an implant-supported restoration that emerges from the tissue in the same way a natural tooth does, yes, it does have that appearance. Is it perfect? No, it is not perfect. But compared to what? If you compare it to an ideal result, it is not. But if you compare it to the potential pitfalls one may encounter should we have chosen to utilize a delayed approach with multiple steps and remodeling of this thin biotype, it's infinitely more consistent and predictable. And I'm glad we made that choice at the time. Following this case, there were several others that increased our confidence in the technique. And in this particular example, you have a patient that has a class 2 division 2 type of skeletal pattern, which many times exhibits also a concavity on the labial plate. And we need to be careful when we look at these kind of cases, that the implant is positioned in such a way that we don't risk perforating the buccal plate with the apical end of the implant, while at the time trying to balance the exit point of the implant so that it is not too egregious to restore. So in this case, we're going to go ahead with the atraumatic extraction, and by this I mean all means necessary to preserve the buccal plate and to preserve the proximal crest as well. So once that buccal plate is preserved, then we're going to initiate the drilling of the osteotomy utilizing a flapless approach. So the initial drill and the palliative twist drill have to be substantially biased towards the lingual. So what you want to do is go through the cortical first and then start correcting for angulation once you start using the actual implant drills. The implant is placed once again with a degree of adequate primary stability, which for us means a minimum of 45 centimeter. We prefer to use a platform switching type of design, and again the implant will be placed towards the lingual with a gap between the implant surface and the buccal plate. Following this, we connect the temporary cylinder, and in this particular case, we're going to utilize the patient's existing tooth, cut off the root, and we're going to retrofit the patient's anatomic crown onto the temporary cylinder, which is going to be subsequently picked up with flowable composite, as you can observe on the screen. The gap is going to be subsequently grafted with a xenograft. I actually prefer not to graft the gap until we're immediately prior to placement of the temporary. So I don't like to have the graft in place while we're going through a restorative procedure just because of contamination issues and so forth. Now we can see the results 4 months later, and you see that there's not only a matter of preservation of the level of the gingival margin, but also three-dimensional preservation of gingival and alveolar contours as well. So we have a situation where the original contours were preserved because we actually retrofitted the patient's own anatomical crown, and now we're going to be utilizing a customized impression coping to transfer this contour to the laboratory. So we have sequential contour preservation and transfer to the laboratory environment. At this point, our master ceramist, Mr. Michael Bergler, takes over and he designs and mills a zirconia abutment, as well as a zirconia coping, which is going to be subsequently layered with feldspathic porcelain. You can appreciate the results, they're self-explanatory. And now we can take a look at the radiographic sequence from the day of implant placement in June to the day of delivery. And you can see, for example, in January of 2011, the remodeling has taken place as a result of the establishment of the biologic width. And from this period to December 2011, you can see that the crestal bone maintenance the crestal bone levels have been maintained. And once again, an intraoral photograph showing the three-dimensional preservation of bone and gingival contours. I think there are many clinicians that will agree with this approach and that have concluded that it is tremendously advantageous to place a provisional restoration at the time of implant placement, particularly with regards to maintaining the gingival margin levels in the midfacial aspects. The problem was that there are a number of researchers, mainly from Linda's group, that have reported that implant placement in fresh extraction sockets would not prevent the physiological remodeling that occurred following tooth loss. And they attributed this to bundle bone remodeling following the tearing of the periodontal ligament fibers after the extraction. So in order to answer the question as to whether or not immediate implants lost parts of the buccal plate or preserved buccal plate, we decided to design our clinical protocol at Penn, basically mimicking the protocol that we had utilized with our patients clinically. So you can appreciate in the selection criteria that we limited the teeth involved to maxillary incisors, and they basically had ideal sites with no perforations, adhesions, in other words, an intact socket. We also rule out any systemic contributory type of issues. The clinical procedure was exactly the same as you have been shown on the previous slides, except that now there's going to be a radiographic follow-up with CT scans taken preoperatively at the time of implant placement and then 6 months following treatment. These were going to be analyzed with standardized measurements, utilizing a custom fabricated stem for every patient, which contain a radiopaque marker, which will help us select the adequate cross-section so that we can actually make an apples-to-apples comparison through the different stages of treatment. These are some of the images, or actually these are screenshots of the cross-sections of the CT scans taken. And I have to perhaps make the statement here that I was unable to manipulate or tweak these images once imported into the Keynote software. So the actual cross-sections are clearer than the screenshots that you can appreciate on the screen. But typically you see the buccal plate to be thin, and in some areas, particularly the mid-buccal area, to be in the order of, well, at least less than 0.5 millimeters. And at day 0, you can appreciate that the implant has been bodily positioned towards the lingual, resulting in a gap through the entire length of the implant. So you can also see that the gap material is restricted. The location is restricted to the coronal third, and that's because of our inability to mechanically condense the graft further apically because of the obstacle presented by the threads of the implant. If you now compare the measurements in terms of thickness space, the dimensions between the external surface of the buccal plate and the implant surface at day 0 and at 6 months, you see that is negligible. And we saw this consistently through the case series. The only exception was this patient, which happens to be the brother of one of our residents at the time, and had the thinnest plate we recorded in the case series. And you see the pre-op CT scan cross-section. It is very thin, about 0.5 millimeters at the osseous crest level, and then less than 0.5 millimeters in the midfacial area. And you see that if you compare now the dimension from day 0 to 6 months, in this case there has been a change of approximately 0.5 millimeters. But nevertheless, there's been complete bone fill of the gap with what appears to be bone to implant contact along the entire length of the gap, at least as far as we can observe radiographically. Some clinicians and others have voiced concerns about the fact that if the gap is too wide, there is the risk of having epithelial proliferation down the socket, which may result in fibroosseous integration. We had a few of such cases in the case series, and we had no issues with survival rates or and such. We always were able to achieve full bone to implant contact and full bony fill of the existing gap. We compiled this data starting in 2007. We presented the preliminary results at the International Symposium on Periodontics and Restorative Dentistry in 2010 at the request of Dr. Ron Nevins. We subsequently were able to finally get the data published in early 2014. And these were our findings. The lingualized implant placement resulted in bone deposition along the gap between the implant surface and the buccal alveolar bone. The gap fill resulted in complete bone-to-implant contact, and this was a consistent observation. The thickness of the labial plate remained essentially unchanged from 0 to 6 months, and the average was 0.1 millimeters, except on that one case that I showed you where there's a very thin plate of bone to begin with, and in that case, we had a change of about 0.5 millimeters. So we concluded that some of these changes are because of the following. The resorptive changes of the buccal plate may actually be a result of surgical trauma from the extraction procedure or implant placement, and perhaps not from a bone-to-bone remodeling process. The fact that we're utilizing a flapless technique may limit the resorption of the external aspect of the buccal plate because the periosteum is not being elevated. The fact that the implant is placed towards the lingual may prevent the resorption of the internal aspect of the buccal plate because there's no impingement on the buccal plate through either the drilling procedure or the implant placement. While we were gathering this data, a publication came out by Caneva and co-workers in 2010 where this group utilized as their control sites a replica of Linde's experiment. So they placed the implant into an extraction socket, and the description is in the three-dimensional center of the socket or the alveolus, and you see that they got the same results as Linde in the histologic section in the center histologic section where a substantial amount of buccal plate has been lost to remodeling. Their experimental sites, however, they utilize a protocol that's similar to ours, where the implant was placed towards the lingual, and actually the head of the implant was also placed 1 millimeter apical to the buccal crest. And in those cases, they did not observe the substantial amount of buccal plate resorption that they saw, that Linde reported, and that they subsequently repeated in their control sites. So to us, this is confirmation of the validity of our protocol in an animal model. The issue we had is that the implant specified for the original case series was the Esthetic implant, and this had to be placed at a minimum insertion torque of 45 cm. To be fair, this is not the most recent Esthetic implant design, but it was the one we utilized. Again, this is in the circa 2007. Now, if the implant did not achieve the 45 cm, then we did not load the implant, and this subject exited the study. So we lost a number of these sites as a result of not being able to consistently achieve this degree of insertion torque. Subsequent to this finding, we decided to start looking for a replacement implant that would be able to consistently provide us with the required amount of insertion torque. So with this exercise where we are using the help of a digital torque reader, you see that what we recorded for the Esthetic implant utilized at the time was around 30 Newton centimeter. And this is what's specified by the manufacturer. It's an implant that was designed to be placed with a low insertion torque. In contrast with an implant with a tapered macro geometry, a more aggressive thread pattern, we found a maximum insertion torque that many times was over 100 Newton centimeter. So what is the purpose of having an implant placed with higher insertion torque? Well, I think the premise is one of primary stability. So as part of the physiologic process that follows following implant placement, you have bone remodeling. And bone remodels because it's responding to the trauma from implant placement, including the osteotomy site preparation and so forth. So when the bone remodels at about 3 weeks or so, you're going to have a dip in the primary stability. And at this point, the implant could be at risk of micromotion. So the rationale for having an implant that is more stable, basically, it is one that will actually place the level of stability at a higher level so that in 3 weeks when we have that dip in stability, the implant will still be stable enough to withstand any type of micromotion. So I think the next question that we should consider is whether or not high insertion torque equals primary stability. And from these papers, it appears that there is a correlation where increasing the peak insertion torque reduces the level of implant micromotion. The following question then is, okay, if we're going to be using implants that are placed at high insertion torques, is this going to cause an issue with regards to pressure necrosis? And we have a number of human studies that actually report that this is indeed not the case. In Kayat's study, for example, implants were placed with insertion torques up to 176 Newton centimeter. And this did not result in loss of osseointegration, in lower success rate, or had any effect in terms of marginal bone levels. And in the other two studies quoted, you see that there's no clinically significant differences in terms of marginal bone resorption, and osseointegration was not affected. There are also a couple of animal studies that actually reinforce this fact as well. This one by Tracy and co-workers, for example, concludes that high implant insertion torque in dense cortical bone does not induce bone necrosis or implant failure. And subsequently, Nevins and co-workers actually shows that placing the implants in a moderate compression or high compression type of scenario actually increases bone to implant contact. And again, they found no evidence of compression necrosis. So if compression necrosis is not a problem, then what are the risks of placing implants with high insertion torques? And that risk is going to be a mechanical one. So we run the risk of actually fracturing the implant, of stripping the connection, of causing some deformation of the associated components, driver tips, etc., etc. So if we're going to be placing implants at higher insertion torques, then we need to make sure that we obtain from the manufacturer the ranges of acceptability where the implant and the components can actually withstand this amount of force. So then what are the benefits of high insertion torque? Well, if it results in more stable implants, clearly there's a potential for placing implants in situations where we may not have ideal sites. This is an example, and this case originally was scheduled for an immediate implant placement and provisionalization. Following flap elevation and coilover, and apparently when one of the residents was doing the extraction, the buccal plate was fractured. So the rationale then was to actually place the implant, and if we achieve primary stability, we will actually just go ahead and graft the case, and now the patient who had a trip to Europe plan could go ahead and return from this trip, and following osseointegration, we could go ahead and expose the implant and subsequently restore. So you can see that the implant is placed in a site that's less than ideal, missing a substantial amount of bone, at least around half of the circumference of the implant. Nevertheless, we get very, very good primary stability, which allows us to subsequently graft. And the patient is now still having a one-step procedure and doesn't have to return. We don't have to stage it, including one surgery for grafting, for example, and then a subsequent surgery for implant placement. Now we're just waiting for osseointegration to actually expose the implant and restore the case. So primary stability is essential for the achievement of immediate implant placement and provisionalization. And pretty much in the same way, crestal bone maintenance is essential for the achievement of maintenance of peri-implant aesthetics. When it comes to crestal bone maintenance, we have traditionally been taught to accept a certain amount of crestal bone remodeling around implants. And this has been typically defined as being about 1 to 1.5 millimeters, and we observe it radiographically as bone remodeling to the level of the osseous of the first thread. Tarnow also reports to us that these defects also have a lateral dimension that's about 1.5 millimeters. And Grunder subsequently also reminds us of the fact that these defects express themselves circumferentially. Taking into account more recent CT scan-based studies that measure the dimension of the buccal plate, you can see that in thickness, it varies from 1 to 1.5 millimeters. So what would happen then to the level of the osseous crest if this 1 to 1.5 millimeter buccal plate needs to now accept the formation or development of a 1.5 millimeter wide circumferential defect? Clearly, it will result in apical migration and potential recession. And at the end of the day, peri-implant soft tissue stability will require crestal bone maintenance. So therefore, it is germane at this point that we initiate a discussion having to do with the factors that may influence crestal bone maintenance. And they're listed, as you see, as conical seal, micromotion, platform switching, abutment, connection and disconnection, and last but not least, the implant surface. So let's take a look at the conical seal and micromotion first. This is an article that many of you are familiar with, and basically it concluded that precision conical connections show no micromotion, and subsequently described a presumed mechanism where there's micro leakage and fluids present in the internal cavity of the implant that will be pumped out due to this micromotion. A subsequent study presented at the 2012 AO meeting, however, shows that even these precision conical connections will actually leak. I think for perspective, it is important that we go back to one of the articles from the classic series of Cochran, Booster, Herman, and co-workers, where the influence of the size of the microgap on crestal bone changes was studied. So the purpose was to evaluate the crestal bone remodeling between implants that had components that were either welded together or held by a transocclusal screw. And what they found was that the crestal bone changes were significantly influenced by possible movements between implants and components, but not by the size of the microgap. In other words, it is an issue of micromotion, not micro leakage. So, what about platform switching? Well, whether you want to call it platform shifting or non-matching or mismatching components, there is a substantial amount of literature with different implant systems as well, showing that this is a valid concept and that it results in crestal bone maintenance. I'm showing you here 4 different papers. They're all reviews. 2 of them are systematic reviews, one with a meta-analysis. And the conclusion is pretty much the same. Platform switching helps to prevent crestal bone loss, may preserve inner implant bone height and soft tissue levels. There is an improvement in peri-implant bone preservation, and it seems to exert beneficial effects on peri-implant marginal bone. So with regards now to abutment connection and disconnection, I think there's very little doubt that whether you're utilizing traditionally designed implants or platform switching implants, you want to minimize the number of component changes, because an increased number of connection, disconnection of abutment and other components will result in more peri-implant crestal bone loss. Lastly, the implant surface, and this has to do with the preservation of peri-implant bone levels and the influence of peri-implantitis. Clearly, if we lose bone due to peri-implantitis, this is going to have a negative effect on soft tissue levels as well, and obviously with aesthetic sequelae. And to prevent this, there are implants that have been designed with hybrid surfaces. Now, towards the corona of the implant, perhaps a smoother or a polished type of surface, so that it will facilitate soft tissue maintenance procedures and perhaps prevent peri-implantitis. And then towards the apical extent of the implant, a rougher surface that will be more osseointegration friendly. Having reviewed all the pertinent issues related to implant stability and crestal bone maintenance, I think it is the appropriate time for us to now initiate a discussion on the immediate implant placement and provisional protocol that we have been utilizing at Penn since 2007. I want to make clear that we only use this protocol in single tooth sites with no defects. Again, only single tooth sites with no defects. If the site has a defect, we then avail ourselves to any interdisciplinary means to actually develop the site into an intact one. Okay? So, once again, this protocol applies only to single tooth sites without defects. And it starts with flapless surgery for obvious reasons. If we do not elevate the periosteum, we're going to then limit or prevent buccal bone resorption. Following is an atraumatic extraction. And again, this means that we avail ourselves of all means necessary to prevent any damage to the buccal plate and to the interproximal crest, whether it is with the use of periotomes or any specially designed forceps. What we want to do is avoid any potential damage to the buccal crest and again to the proximal crest. The implant selected has to be one that will provide a consistent amount of primary stability. And for us, that means an implant that will have a tapered microgeometry and an aggressive thread pattern. The implant has to be placed towards the lingual with an insertion torque minimum 45 Nm. Final implant position will be towards the lingual, resulting in a minimum 2 mm gap between the implant surface and the buccal plate. We'll also place the implant 1 mm below or apical to the osseous crest, for the purposes of having a safety zone just in case there's some bone remodeling that we are not going to have the top of the implant exposed. It is very important that the implant is not positioned buccally, and this means drilling the osteotomy with a lingualized bias from the beginning, as I mentioned to you. If you read all the reports, whether it's on animals or whether it's on humans, where immediate implant placement resulted in recession, you will see that they're mostly associated with buccal placement. If you take a look at the materials and methods and read the description of how the implant was placed, invariably they're going to describe a situation where they place the implant in what has been called the tridimensional center of the alveolus or socket, or following the apex. If you do this, the final position of the implant will be buccal. So therefore, we advocate an osteotomy preparation that starts very early on with a substantial lingual bias, which will be corrected when we start now with the proper implant drills. So the gap that results from the lingual implant placement will be grafted with a xenograft, and this is due to its slow resorption characteristics, which give us stability. Many times I'm asked about the alternatives, and for us there's none. So we do not believe that it is appropriate to use a faster resorbing alternative in this particular case. Following is the placement of an immediate provisional restoration. To be clear, I prefer to delay placement of the graft until I'm ready to actually deliver the temporary. I do not like to go through my restorative procedures, including use of any of the materials, with the particular graft present, just because of concerns for contamination and so forth. So the use of an immediate provisionalization is beneficial, particularly when it comes to preserving the gingival margin levels around the mid-facial aspects. And there's a couple of alternatives for this. One is a traditional approach where you may actually do a wax up and fabricate a provisional. I prefer to include in my wax up these wings that will serve as seats when I'm actually placing the provisional and trying to drill some space so that we can actually go ahead and pick up the temporary cylinder. So once the temporary cylinder is picked up, we can now identify the appropriate contours. So we have the critical contour area, and we subsequently just fill in the contour that we desire to have in what has been called the subcritical contour area. If I had to review this slide to reflect what I do nowadays, you will see perhaps a more aggressive CJ-like structure that will extend perhaps 2 millimeters following apical to the gingival margin, and this will provide support in the critical contour area. Apical to that, I will probably under contour. So in the critical contour area, you need the shape that's essential to maintain the contour of the gingival margin. In the subcritical contour area, by under contouring, we provide space for the tissue to actually be thicker and perhaps resulting in more stability. And this is our own preference, is a clinical preference. It is anecdotal, and there's not much evidence with regards to this or actually contour in general, to be honest with you. So the other technique is one where you will utilize an existing restoration, typically full coverage, a crown or something of that nature, and then or the patient's own tooth. So in this case, for example, we have the patient's clinical crown that has been removed from the root, and we're going to be retrofitting this to be utilized as a temporary restoration. It is not a technique that I would recommend for your first case. It requires a little bit more of experience. So I prefer to utilize also a placement jig that will allow me to seat the anatomic crown in pretty much the same way it was positioned prior to the extraction of the tooth. And you see here that it is seated over the temporary cylinder with no impingement whatsoever. We subsequently remove it and go through the different stages of adhesive preparation, after which it is placed back in position and now picked up with flowable composite. Once the contour has been worked out, adjusted, etc., I prefer to cut back the temporary cylinder aggressively so that we have sufficient space to now place a thicker layer of opaque composite, eliminating the need to use any type of opaquer to mask the gray appearance of the metal temporary cylinder. And now we can appreciate what it looks like at day 0 and at week 5. And one issue with these type of provisionals is that they're very, very durable. So the patients typically are in no rush to come back and have the final restoration delivered. In this particular patient's case, she's a very busy physician, and we had difficulty getting her back in due to her schedule. So you see the appearance now at 18 months compared to the preoperative appearance. And if you take a look at the CT scan taken at 12 months versus 18 months, you see that we have indeed preserved the buccal plate. So the last issue that I want to discuss is one of occlusal management. And I feel that this is something that it is not emphasized sufficiently from the podium or in publications as well. I believe that it's not enough to tell the patient to be careful what they chew or these are your party teeth and you should limit their use. Patients are patients, and once they start feeling comfortable after a few weeks, they will basically just perhaps ignore your advice or lower their guard, and that may subsequently cause some problems. If you're in private practice, loss of one of these immediately loaded implants is not very good. It is difficult to handle from the patient management perspective, and it is, in my opinion, much better to take whatever steps are necessary to ensure that you have no failures. So if we take a look at the photographs to the left of the screen, this is the patient that I showed you initially who delayed returning for the completion of the final restoration for 18 months. And you can see that she has such a deep overbite that the incisal edges of the lower anterior teeth pretty much contact the soft tissue on the palate. The other two cases are such that you see the presence of parafunctional habits as evidenced by the presence of wear facets. All these three cases were managed with removable appliances so that the vertical was increased in an effort to avoid any type of contacts anteriorly. The problem with this is that they're only as good as the patient's compliance. If the patients don't wear them, basically then they do not serve their purpose. Our preferred technique is one where we actually open the bite by placing composite on the central fossa of the maxillary bicuspids and first molars. It is enough. I tend to insist on having bilateral contacts, and obviously these have to be adjusted so that the patient is as comfortable as possible. I prefer to do these a couple of weeks prior to the actual procedure so that the patient can get used to it and we have the opportunity to adjust it should it be necessary. It is not essential to include the second molars because of the fact that, well, it's not needed for support and it is more cumbersome to actually work further back in the mouth because of moisture control issues and so forth. It is also helpful if we utilize a composite of a contrasting color so that following osseointegration, when these are going to be removed, it is then easy to see where the composite ends and the patient's enamel starts. So many of you are now going to be wondering whether or not increasing the vertical dimension is going to have any kind of effect on the patient's temporomandibular joint, the musculature, or anything like that. And I'll tell you that this is not a discussion that we should be having in contemporary occlusal circles. The concern doesn't have to do with TMJ, it doesn't have to do with the musculature, but it has to do with the potential for intrusion. And this typically occurs around the bicuspids. It's not going to be all of them. You see one, at the most two, and it's going to happen more than likely in cases where patients have a deep bite and because they have this hinge-like type of occlusal pattern. So in those cases, what you're going to do is remove the composite following osseointegration, and you're going to recall the patient 3 or 4 weeks later, and invariably you will see that contact is reestablished. So this is not something to worry about. It's completely reversible. And again, all concerns having to do with the effect on the musculature or on the temporomandibular joint due to the fact that we are increasing the vertical dimension are unfounded and not substantiated by the literature. So, in conclusion, when we are placing a single tooth implant in the aesthetic zone, we have a couple alternatives. One is the immediate alternative, the other one is the delayed alternative. If we have an intact site, we would basically prefer to use an immediate implant and provisionalization protocol whenever possible. To us, preservation will be more predictable than regeneration. So because we're working with intact sites, then there's more to preserve. So therefore, the integrity of the margin periodontium will be an accurate predictor of the aesthetic success of the implant procedure. Finally, if we place an implant lingually and provisionalize it as has been indicated with our protocol, and selects a fixture that provides adequate amounts of primary stability and crest bone maintenance as well as resistance to perimplantitis, we may be able to achieve sustainable periimplant aesthetics. Finally, I want to thank you for staying with me through the duration of this seminar. If you have any questions, please don't hesitate to shoot me an email. You see my email on the screen, drernestolee@gmail.com. We are proud members of the Penn community. As an alumnus, faculty, and colleague, and I'm going to take this opportunity to do a little bit of flag waving. And I also want to make you aware of the fact that we have a teaching center, which is housed in an annex next to our private practice, and we are going to be featuring an intensive clinical hands-on training and life implant surgery course as well in September. And for any additional information, you may visit our website, www.drernestolee.com. So I want to thank you once again for your kind attention, and we hope to see you around soon.